Well, good morning. I not consider myself an expert because I would say it's going to be too much to say that I'm an expert in leukodystrophy, but we face the same challenges in patients with leukodystrophy that we face with other kids with some other conditions. The idea is to talk a little bit about what we see, what we do, and how can we work together to help our kids, our adults who have these conditions. The idea today is to talk a little bit about what is vision, how do we see, of course, how leukodystrophy could affect the vision, and how we evaluate the vision. It's important also to know what we need to do to know how our vision is doing, and of course, what can we do, and of course, the idea is to have a nice conversation, and if I'm able to answer a question, and if we all together can get better and new ideas, that will be great. Well, when we talk about vision, and probably when we mention about vision to anyone, the people tend to simplify this too much and think about visual acuity. In other words, how much is the smallest letter that you can see on a board? But vision is not just that. Some people could have a perfectly vision, the one that we call 20/20, but struggle a lot in the everyday activities because they have other deficits. Vision is, of course, visual acuity, but also is color perception. We live in a world that we perceive different colors. Different color means different things. Could mean even danger, be careful, something's going on, or it could mean, oh, such a wonderful world that we can enjoy around us. Contrast sensitivity, that's another thing. It's very easy to see something, a black letter over a white background, but it's not as easy to see a gray letter over another grayish background. Visual field, when we move around, we're so used to know where we are placed that we don't have like an active conscious about our visual field. We just assume that we can see where we move. We don't step over things. We don't bump on things because we can see and we avoid those objects. But it's very important for us to have a wide visual field. Of course, our vision in the night is different. There is a different system that processes the vision in the night. And of course, the depth perception that we call technically stereopsis. And this information, of course, is captured by the eyes, but it's the brain, the one that processes that information. At the end, we see with our eyes, but we see with our brain. And that's the reason why you have an eye doctor today here talking about vision when we're talking about leukodystrophy that mostly affect the white matter in the brain. We don't have white matter within the eye because we need the eye to be so transparent that the nerves that they are within the eye doesn't have a myelin covering the nerve to allow the light to cross all that structure and reach the photoreceptor, the cell that captures the light. But we need the myelin in the central system to help us to send information in an appropriate way. Well, how do we see? Our eye, the main function is that we will capture the light and we will send this light to the central part of the retina. There are some special cells, the photoreceptor will capture the light and will transform the light in a neural information, in a neural signal. But after that, we need to send this information back to our brain, and in that way, the information goes from the eye, some of the information crosses, but at the end, what we have here in all this part that the white matter is, we organize the visual information, and we transfer that information to a specialized area. Then the simple information that we capture in the eye have some other areas within the white matter that start transforming that information in a more organized visual stimulus to finally reach the visual cortex. But the vision doesn't stop there, because we need that after the posterior part of our brain capture that information, okay, it reacts to that, but now we need to integrate the information and give a meaning to the information and react to that information. We don't see just to, oh, enjoy the environment, we react to the environment. And for that reason, we all the information that reaches the posterior part of the brain need to go forward again to different areas in the brain to give an idea of where, how, motion, perceive the space, the location, where we're located. Other areas to perceive colors, form, and also to recognize. Now, for example, I'm seeing you, my eyes are capturing the light that is reflecting in the surface of your body. I'm receiving the light, my eyes are sending that information back to the brain, but for now it's only light. And then it's only a neural signal, but my brain, after receive all that information, connect with other areas, and it will tell me, oh, there's tons of different tables. Oh, I see chairs. I see people. Oh, they are almost sleepy with what I'm talking at this point, and I can react, I can modify what I'm doing, seeing that. But for that, I need the integration of the information. And that part could also be affected when the white matter is not healthy. If we try to simplify this, we always have, maybe listen to the example about the leukodystrophy, how affect the white matter, and they tell us about it's like a cable that couldn't transfer information in the same way. I'm going to use another example. For example, how many of you work at home remotely? And how many of you need to commute every day to go to work? Okay, I think we're going to stick with the electronic example. Imagine that you're trying to work. Oh, sorry. And our system is like the cameras trying to capture information. You're in a Zoom call, and then that information needs to be sent to the modem. And it's here where, in our brain, that could be affected when the myelin is not present or is lacking, or is in a small amount. The information couldn't go in the same speed. It's slower. Then part of this information will reach the central part of the brain. Then we have this like a modem that needs to transfer that information. And we have finally the brain that they need to transform all that information in an image. And we need to react back to that. Imagine a Zoom meeting where the connection between your camera and the modem is slow, or then from your modem to the computer of the other person is slow, and then the other person is trying to react of what you're telling them, what you're showing them. If they couldn't see that, for sure the reaction of that person will be completely different. And also, if they send you a response or an answer to that, if the connection is not in a good speed, you're going to miss a lot of that information. At the end, you're going to be awful. And what happened to all of us when the Zoom starts cutting? We get desperate. We start thinking in other things. And our brain is almost the same. We start losing attention. We start, in the case of the vision, we start having visual fatigue. We lost attention to the thing that matters. And it's harder to keep track on the visual information. Already was mentioned, leukodystrophy is a heterogeneous group because the visual impairment could be different. The age of onset of the impairment could be also different. Even for the same type of disease, could be in different times. There are some other disabilities associated that also could impact the vision. If I have, of course, difficult motor skills because of the leukodystrophy, it's not easy to hold a text, to aim or hold my head still to look at something, and that could affect also my visual attention. And then we have all this other mixture of deficit. And at the end, what is more important, each patient itself is a universe. The same patient, different patient with the same disease, with the same onset of the impairment, could have completely different challenges. Then, as I mentioned before, we have this problem, the communication between the brain and the eye. And if we look at and tell me, for me it was hard trying to find the literature, how many of the patients with different leukodystrophy has vision problems or ophthalmological finding, and it's a high number, like 2/3. But it's so variable for each condition that you can see in some patients a very significant deficit. And it happened to me. I probably see kids with very mild conditions or kids with a very severe condition that they're almost blind. But all the other patients who are in between, sometimes we don't see them because they're struggling with the motor challenges, and sometimes we are not aware that they can have challenges in their vision. We have a lot of kids who start struggling at school, and they go to a regular eye doctor, and about the question of how to engage other doctors, they go to a regular eye doctor, they take the exam, oh, you don't need any glasses, bye-bye, and that's it. But the patient is still facing challenges in the school. Then that means that we didn't answer the question or the concern that that person has, because we use just a standard way to see them. For that reason, we need to open our eyes, and about the question how to engage the doctors, please teach us, ask us about what do you need. You as a family of a patient of who's having a leukodystrophy, or if you have a disease, you know more sometimes than the doctor that is in front of you about the disease. But we have another skills that we can use to trying to see other things, and we can work together as a team to find ways to help your patient, your kid. If we look at how the leukodystrophy affect the ophthalmological system, we know that, and I know that yesterday was mentioned in multiple conferences, nystagmus maybe is the most frequent, more constant manifestation. Some kids have strabismus, and some kids have this. That is the difficulties to keep the fixation on things that they are looking at. And this is really hard to measure this. There's no standardized test to see that. And it's really hard for someone who is doing the exam to notice, oh, your kid has a fixational deficit, because you don't have enough time to check that. Or also, during the day, there's some moment that the patient has better visual attention than others. Also, the evaluation could change during the day. From the sensory part of the vision, we have patient who finally will develop optic atrophy. This is the atrophy of the optic nerve, but something that we can see, if we use optic atrophy, some patients they don't have a problem with that, but if we do the test, we can see thinnings of the nerve, we can see how the information through the nerve is slower. Of course, this could produce a visual function loss. Some patients who have some rare retinal degeneration, the first part of the capture of the light could be affected. And in some conditions, the patient could have cataract. Cataract are when the lens that is in front of the eye gets some opacity, and for that reason, we couldn't send all the light back to the eye. Okay, but how can be this visual deficit? Some patient could have a vision that looks completely perfect, but some patient could have some deficit in the visual field, some areas of the visual field that they couldn't see well. Sometimes these areas could be, yes, in the very center, and that will affect mostly the visual acuity, how much details they can see. But also, this can affect the peripheral visual field, and that affects a lot the mobility. Then we have a patient who has some difficulties to move, but the same, we have a problem with the perception of the surroundings, and that's the worst combination, because we expose the patient to dangers if we don't take care of this problem. And I would say this part sometimes is overlooked because we're more worried about the mobility issues, and we don't look at this, the visual field deficit that they could have. Or sometimes the patient has a good acuity, and as I mentioned before, the contrast sensitivity is not too good. This happens when the nerve is affected with optic atrophy. And you can see the image could be blurry. If we put more light, maybe it's going to be better. Or we can have this condition that I would say nowadays is one of the things that we're trying to define better. The neuro-ophthalmologists, neurologists are trying to standardize the diagnosis of this condition that is called CVI, cerebral visual impairment, or known somewhere like a cortical visual impairment. In other words, our eyes can see, but our brain couldn't interpret that visual information. And again, this is a big spectrum. We have patients who can see 20/20 and can do great in a simple task. If, for example, if I show them a picture of myself, they say, oh, that's you. But if I show a picture of myself within the audience, if they try to find me, they couldn't find me because they couldn't identify that that guy that was in the other picture is the same person. But also has this spectrum that kids are completely, or patients are completely blind because the brain couldn't use any of this information. But doesn't matter how much I can describe all this deficit, the most important thing at the end is to know, okay, we have this visual deficit, but how this is impacting my daily activities. And that's, I would say, is the part that sometimes we as an ophthalmologist, we don't see. We tell you, oh, perfect, you have a great visual acuity. Or I tell you, oh, you have this deficit. But sometimes we are lacking in the care of how that is connected with your daily activities and how are those impacted. I want to stop a little bit on kids because, of course, I see a lot of pediatric patients. That's my area. Someone could say, okay, yeah, the vision is only one more of the senses. But the problem is that kids are also developing. When we talk about leukodystrophy, we can think about all the deficit that the disease can produce. But we need to think that it's different depending on the age of the patient. When we have a kid, it's not something that we are having deficit on something that we already reached. We have kids that are still developing the connection at the brain, then they're still developing skills to be able to have autonomy. Then we have all the other sensory system, touch, olfactory, auditory, gustatory, and sense of our body. But not because I'm an ophthalmologist, but 80% of the stimulus in the kid to trigger the development are visual. When you see something, you try to grab that. When you try to grab that, you start producing some motor stimulus. Okay, when you finally grab it, oh, you touch it, oh, and you learn an initial thing, how does it feel? When you can grab it and you can approach that to your face, you can taste it, you can smell it, and all that create a very integrated sensory experience that finally gets stuck in your brain, and your body now knows how that is. Then you can see later a strawberry, and you can feel the taste, the smell, all the experience that you have with that, and just seeing that. But we need to be sure that the patient, of course, have the visual stimulation. As I mentioned, we learn how to move, we learn how to balance, we communicate, we interact. One of the things that affect more, and I will put now the attention to the families. All of you are super engaged with your kids who have this condition. But some families, sometimes they're not too engaged to the kids who have this complex condition. And sometimes if you're having a significant vision problem, because the kid doesn't look at you, that can produce a barrier that separates the families, the parents with the kids. And that's a disaster, because if you have parents who are not engaged, they're not going to produce a stimulus, and the lack of stimulus will produce more deep developmental delay. It's not going to be something that you're going to lose. They're not going to develop those things. Then we need the vision to have communication, develop our interpersonal skills, of course, language. We learn how to communicate. We learn how to interpret words. For example, animals learn more with how this thing sounds. You can tell them a terrible word with a nice sound, and the pets feel super happy. And you can tell a super nice word in a terrible sound, and it's awful. For us humans, we react of the expression of the faces when we're saying a word. You can say the same word using a different facial expression, and that means something completely different. Then it's important. Vision teaches us how to communicate. And of course, give us a concept of this space. Even though if later on we lose the vision, if we have an idea of how is our surroundings, even we can know that when something sounds like the door that was open there, I know, oh, it's a door over there. If you don't have the idea of the space, you can hear sounds, but you couldn't localize the sounds or the meaning of those sounds. And I would say the most important thing in everyone, incidental learning. We have a lot of experts here, but if we ask them, a lot of time in science, some of the biggest discovery came incidentally. Some mistakes, some new observation, we're aiming for one thing and we discover other thing, and in our daily life is the same. Okay, but how we evaluate the vision? We can have the standard eye exam, and of course we can do a functional vision assessment, and the goal of each evaluation goes to different things. The standard eye exam include, of course, assess the visual acuity, color vision, to look at the motility of the eyes, because of course eyes need to aim to the same thing to make the vision easier. And we need to see the fundus. We can see the retina and the little things there, that is the optic nerve. Sometimes we need to do some extended tests, but I can tell you a secret. Sometimes these tests are really challenging in patients who have some other developmental problem, or even just the wheelchair. Could be difficult because we don't think how to adapt this test to those patients. And we couldn't put the patient sometimes in front of the machine to do any of these tests. And that's a problem because we don't have that information at the end. But we can do this, the OCT. It's a special test just to see how thick the optic nerve is. And sometimes we find that the nerve is thinner than it should be, but the patient still have good vision. Sometimes we can do this map of the visual field. It's like we're showing a light, and every time that the patient sees the light, they can click a button, and we can map the area of the visual field, and we can map some areas that they couldn't see. And sometimes, for example, patients that are nonverbal, also we can do other techniques. We can do one that's called visual evoked potential, that we display a stimulus in front of the eye, and we can capture how much response that produces in the back of the brain. The problem is that it only tells us in one way how much of that information is reaching the back of the brain, but it couldn't tell us how much the brain is integrating that information. Sometimes we have this test that is just to measure the response, and we can measure the time, and we can say that the time in most of these cases, especially in the condition who has a significant demyelination, it's a very, very long time. Because one of the things that happen in the leukodystrophy, because we don't have the myelin around the nerve, the information travels much slower. And also, there are some other techniques that try to estimate the visual acuity. But again, we can have a patient to show a perfect visual acuity with a test, but it's not able to integrate that information and produce a meaningful vision. At the end, the standard test helps to diagnose the visual deficit, but not the impact of this in the patient life. And also happen that deficit that may not be a disability. I want to try to separate this. One thing is a deficit. Okay, I couldn't see this size of letters. But the other thing is the disability that produces. A patient who is in school age, of course, not seeing something in the smaller letters, if they don't have any adaptation, that produces a lot of challenges. And if we don't take care of that, that's a disability because we're not allowing them to do things with that vision. But sometimes if we put some adaptations, it's not a disability because already the patient has adaptation, is using the adaptation, and is able to do the same as the other kid who doesn't need the adaptation. For that reason also, you can have the report from the eye doctor that can say, oh, your kids have this or that, or you have this or that, but then how that affects you in your work, in your studies, in your life at home, all those things depend on other things. And you as a families are the one that can see that. And here is the part that the functional assessment has a new role. It's trying to identify the disability, trying to help, okay, what are your visual tasks? We couldn't fix everything, but at least we can improve what you have. And then we need to prioritize, and this should be like a stepwise process. Okay, we prioritize the things. When that are fixed, we can move to the next one. Because also happened that when we have some challenge in this level, we are able to move to the next level, and the next level produce completely different challenges, and we need to address those in that moment. Then this is a continuous process. And we can use some assistive devices like visual aids. There are some opticals, non-optical. I'm going to show you some example, and some assistive technology. At the end, the goal is to improve the visual efficiency to facilitate inclusion. But again, every child is unique. You can see some picture of kids using different things. Kids have, a kid who have, let me see, a kid who can recognize images in a chart, and they're using a slant board to make him easier to look at that because of the position of the patient. But also we have a kid with very, very low vision that we're trying to get the patient engaged with the vision. At that point, we don't care if the patient could recognize what is seen, but we're trying that the patient has a reaction to a bright object, for example, a bright light, a bright toy. In this case, it's like a Miller paper, like the patient touch it. Sound is like a nice thing when the patient touch it. It has this shining surface, and the patient is not recognizing the text, but we are trying to provide information that create connections. And sometimes they're so low the vision that we can use this kind of illuminated table to produce a very high contrast and allow the kid to try to track the attention to this object. This kid has another condition. He didn't have a Leukodystrophy. That was a kid with a cerebral palsy, but it was a kid that was at the beginning of the therapy completely blind for everyone. Everyone thought that the kid couldn't see anything. And after a few weeks of these exercises and looking at this very high contrast object, he started engaging in a better visual behavior. And that also improved his motor skills, because now the kids start trying to move, start helping a little bit with the neck tone, and then we saw a lot of other development with this. In other words, don't get completely discouraged when you think that the person is not seeing. Sometimes with this very basic kind of thing that trying to attract attention to visual symbols could be enough. But here's the most important, and this is your task. Recognize what are the challenges at home, okay? And we spend as a doctor, maybe in a regular visit could be, 15 minutes or 20 minutes, or 30 minutes. In a functional evaluation, maybe 1 hour. But that could be the best hour of your kid, or it could be the worst. And that doesn't give the best idea about how is the everyday. But you're seeing them the 24 hours, then you know what are the challenges. That's a summary, a lot of things that we need to do. But nothing of this is enough if we don't work as a team. There's a summary. At the beginning, if the onset of the condition is very early, we will focus on development. If the kid is older and the deficit is low, we will try to see how we can help them to succeed at school, then to be independent. At the end, if the deficit is too deep, we're trying to see how we can protect them to avoid that they are being exposed to risk. And the same with the adults. Then what we do, we of course treat any associated eye condition. That's what we do as an eye doctors. We work with the low vision specialists trying to find low vision adaptation. These are, for me, the superheroes in this thing. The teacher for children with visual impairment. This can work in the school system. The thing is, this is different in every state. Some states have these TVIs in the school system. Some other state doesn't have this. And that's also something that you can do as a patient. Ask for these resources to your own state. It's not just the medical care. This everyday kind of support is important too. And also, we need a specialist in orientation and mobility. And that needs to be done in a known space, your home, trying to identify risk within the home, trying to identify how to help to navigate better, and also to find strategies if you are exposed to a different environment to keep you safe and being able to move from one place to another. This is our very simple thing that doesn't need maybe to go and see the eye doctor, and I put the list here because maybe you can take an idea of this. When you start struggling with the first milder deficit, okay, something that you can do is use a slant board. Sometimes with the position of the reading test, we couldn't hold the book well, we couldn't hold the text. Okay, use a slant board. We can put that closer to us, we can have a light from the top, and that's very simple. We don't need a gene, nothing, no molecular super new discovery. We need just a piece of wood or cardboard or anything that could create this slant board. Just as a comment from the previous session, those things remain important. And those things nowadays, I would say, if for medicine and research, gene and molecular diagnosis have been the big discovery of the last few years, I would say the 3D printing for everyday things is a huge thing. Nowadays, we can print things specialized for everyone to adapt the object to make it easier. Then you can, no matter the chair that you have, no matter the table that you work, you can always find a place that you can create a personalized object to make this better for you. Just adding a light that increases the contrast. If I have more light, my paper is not anymore gray, it's white, with a contrast of the black text. That increased contrast, reduced visual fatigue. For example, probably all of you have heard from grandmothers, oh, don't read with the low vision, you're gonna get blind. That's not real, but of course you have a lot of more eye fatigue when you read with poor light condition because you struggle more trying to identify the text in this low contrast environment. Try to keep objects and text as much simple as we can. We need to avoid the crowding images or text. The background should be solid. Sometimes we love to put this background with images. Those are awful for person who struggle with the vision. Just a white background is enough. And of course, we need to ask for extended time, be able to do breaks to reduce the fatigue. I already mentioned about the orientation and mobility to be done in known safe areas and unfamiliar areas. And I would say eye protection is very, very important. Here's an example of the different, just the simple slant board, different kind of magnifier for near, telescopes to see for distance. And nowadays the technology also helps. Phones has apps, tablets have apps that allow us to increase the text. Sometimes if we are struggling, okay, I couldn't see well, maybe I can get the phone and let me see if it works. Of course, it's not going to work, because, but for example, I'm too far from that screen, and I can start asking. Anywhere. And if we couldn't see well, that help us. There are also some apps that you can say, okay, I'm in the grocery store, I need to find, I don't know, rice. And you know there have tons of different packages there. You can write the word there, and you can take a photo of in the hallway, and it will show you in the photo where the word rice is. There are some apps that you can use for that, okay? And that simplifies things a lot, even for a person without any vision problem. But I would say, every device can be powerful, but we need to set up properly. If, for example, you like cars and I take some of you to drive the most modern new car, most powerful, maybe it's gonna be a mess. You're gonna make a disaster and you're gonna be afraid to get in that car the next time. Because we need to use the tool that fits better to our needs and to our skills. And for that reason, it's important to consult a low vision specialist. Sometimes people who start struggling with vision start just grabbing things that they find in Amazon, but maybe it's not the best fit for you. And the people is discouraged of use those devices because, oh, I tried this, it was expensive, and it didn't help. Of course, it didn't help because you didn't use the one that you need, or if you use the one that you need, you didn't get the proper training to be able to use that in the best way. Not ask about people using any kind of devices without reading the manual and not using all the resources that the different devices has. And at our home, of course, we can do simple things. Let's modify the light. Try to use a good lighting without glare. Direct lights are not the great. Sometimes we can use light, indirect lights. We can find surfaces that are not too shiny. Nowadays, we can have nice tables that are easy to clean, but without this shine surface that is confusing when you see all this reflection and you could identify things well that are over those surfaces. Sometimes you can use some labels. If you're struggling to process the visual information, maybe labels could help, okay? And of course, organize your space. Try to make the space predictable. Don't put things in the middle of the hallway. Trying to make everything easier. It's not going to be also good for the person who is challenged with all these visual difficulties, but also it's going to help you. And something when nothing can be done, and we always forget, is protection. It's important if you have a vision problem, and also, especially if you also have some motor deficits, to use some goggles or just plano lenses for protection. Our eyes maybe are completely healthy, and it's the brain the one that is struggling, but we need to keep the eyes safe for getting any trauma. And we see a lot of patients who have low vision, and then they have a trauma. And trauma could be just like, okay, we're in a place and someone else was moving something and hit my eye. And because we don't have our protection, like we couldn't react and put our hands over there pretty quick. If we have low vision, we couldn't just close the eyes. And an injury to the eye can produce significant problems. You would say, okay, but if you couldn't see, it doesn't matter. Yeah, it matters, because you couldn't see now. But we don't know what's going to happen in the future. And also the eyes produce pain. They give you a nice facial structure, and again, that help to connect with people around you. At the end, we are not, if someone tells you that by themselves they can do everything, that's also a lie. The same with the Holy Grail. There is not someone who has the answer for everything. And your support team, a patient who has low vision, include the eye doctor, neurologist, of course, the research scientists, we need them, but we need the educators. We need the pediatricians who see our kids, our patients, they know them better than anyone else. And we need the occupational therapists, physical therapists, and speech therapists. If you want to go fast, go alone. That's fine, you can do it. But if you want to go far, go together. Thank you. Okay, it was 40 minutes. Right on time. Does anyone have questions or comments?
Can you hear me?
Yeah, now.
Okay. My name's Abby. My son William is 11, and he has Kreft leukodystrophy, almost completely immobile, relies 100% on caregivers. One thing he has started to learn is to drive his power chair with his Tobii Dynavox. But one of the issues that he is having, he has a TBI, we're in the state of Iowa, so he has a lot of therapies. But one of the issues that he is having is the fixational, or the dwelling, is keeping his eyes fixed in one direction without looking away. We're having some difficulties finding some therapies that would strengthen that, and I didn't know if you had any insight or any programs or anything that would help just that part of the vision process, just the dwelling, being able to fixate on an object.
Yeah, unfortunately, I would say that's one of the most challenging things, and especially the kids who have this more severe condition like Kreft disease that have significant motor deficit, and also is the one that affects maybe the vision more than anyone else.
He uses the communication part pretty pretty well, which is outstanding. He
Yeah.
amazes us. But just the dwelling is just a very, very difficult part of what he's going through right now.
For the fixations, nothing. Sometimes the way that we set how we set the devices to, instead of having to, everything has pros and cons, because sometimes you can reduce the amount of things that are displayed there, but at the same time that make them that need to move to different screens to find the things that they want.
Yeah, it has, so he has like a forward, left, right, and reverse. And he can see it, but then staying, on that specific direction is really, really hard. And he gets frustrated, and then, he's 11, and then he's done. So that's been our...
I would say that, yes, you need to don't push him too hard with that. Just allow him to do the breaks. I would say sometimes frustration is a worst thing because they don't want to engage with that. And our process, you have some moments where everything is easier, some other days that is harder. Unfortunately, I don't have a good advice or suggestion for that. But I would say at that age, we see a lot of kids with vision difficulties or special needs that struggle a lot at that age because they are aware about the condition. They start becoming to be teenagers, then they start questioning things again. Sometimes some of our patients, they want to get rid of all these extra things, or sometimes they just, instead of trying to use it, they prefer to, okay, don't bother me, I'm gonna disconnect from this. But yes, sometimes they need reassurance and time. And of course, as a parent, could produce a lot of anxiety and desperation. Just trying to be calm, because you are the rock that gives them security and support for the next step. Just give it time.
Yeah. Well, thank you very much. I appreciate it.
Yeah, I think they need the microphone back there.
I misunderstood, sorry.
Thank you for wonderful information. I have a couple of questions, if you don't mind. I would like to know, I have a daughter, she turns 14, and she has HABC leukodystrophy, hypomyelinating leukodystrophy with atrophy and basal ganglia. And I would like to know, is it worth it to have strabismus or nystagmus surgery for that to be corrected? Because of the couple of reasons. She already had one in 2019, and it's coming back. And I meant on strabismus specifically, because we have to be aware of the risk of anesthesia. So is it just worth it because, muscles are kind of weak?
Yeah. First, for the nystagmus, I would say no, even though that's some strategies trying to reduce nystagmus. The only thing that is worth it when there is a nystagmus and the patient has, for example, a head tilt to keep what we call a null zone, an area where the nystagmus is slower, something that is worth it if it's possible to fix the position, because then maybe just moving the position of the eye, the patient can be in a better position, that they can hold head in a better position to see well and make everything easier. In that case, it's worth it, knowing that because all the other central and neurological disorders, maybe it could relapse later on. And for the strabismus, I would say it will depend if there is a binocular vision or not. Sometimes the kids, when they start with the strabismus at a very early age, they don't develop the binocular vision. And sometimes even that they could have the eyes aligned after a surgery, they keep using one of the dominant eye to see things. And if you need to balance the risk of any surgery, anesthesia, it will depend a lot of, I would say, if they have the potential to use both eyes, of course, you should try it. Okay. Also, sometimes the kids benefit for the strabismus when it's too far one eye from the other one, trying to bring the visual field to the front of the vision and attention. But I would say it depends. Something that can be done sometimes just to cover the a deviated eye and see any changes. Sometimes we can use one thing that we call prism to displace the image to the position where the eye is. And if you notice with that an improvement in the vision skills, for sure I will go for a surgery. But if you're using a prism that's trying to fix the deviation of the image, and there's no improvement in the visual activity, I would say, maybe you can defer that and consider that the surgery is going to be more reconstructive or cosmetic more than a functional surgery.
Mm-hmm. She also have astigmatism and myopia.
Sorry?
She also have astigmatism and myopia as well.
Yeah, well, sometimes it's important when a patient has strabismus and also refractive error. Sometimes the position of the eye within the lens, especially if it's a high refractive error, also could displace the image. Mm-hmm. But also when they have glasses, especially, it's a good moment that you can try. There's a film that can be put on the front of the lens that is called Fresnel prism that could displace the image. And that's perfect to try on that and see how they can see. And of course, trying to identify if the problem is the strabismus, is the refractive error, or maybe it could be one of these other things, the processing, the contrast vision, that those things are not going to help, they're not going to improve when in a strabismus surgery. Then it's very important that to talk maybe with the eye doctor who's seen her to define what are the goals for this possible surgery. What are you expecting to have after that? Because sometimes the goals doesn't align with the needs that she had.
Mm-hmm. Okay. Two more?
Go ahead.
Okay. I know you already have spoke about like different kind of things like TVI and stuff. I don't have feeling like the ophthalmologist is really helpful, but we have been seeing at the Glenview Lighthouse, which is actually Vision and a Rehabilitation Center in Illinois, and they're really helpful, but do you have any other advice or questions I can talk to Rehabilitation Vision Center for her specific conditions?
Well, first of all, this is going to be in the Zoom recorded, but I agree with you that the ophthalmology center, we don't help too much. Because sometimes we are too focused in the eye as a structure, and if we couldn't do surgeries, we don't know what to do, and we know a lot about eyes, not too much about vision sometimes. I'm talking about general practice because, of course, you have places that we work with a lot of kids with special needs, and we know how it is. But it's a challenge, of course, and could be frustrating for families when you go to the eye doctor. But that information is important too. Of course, you need to rule out any of these other conditions that sometimes could be treated. But I would say some of the specialties that helps a lot are the optometrists, with especially in the low vision and functional assessment, because they can do a general eye exam and they can refer the patient to an eye doctor if there are anything that need to be treated with more complex care or surgery or medication. But they work pretty well. Of course, every state have different resources. Some states have this, and by the way, we need to don't be afraid about the word blind, because we used to think about blindness like full darkness. And nowadays, blind is someone who struggled to see in the regular, I would say, activities. There are, of course, by the law, different definitions, and different states have different sometimes requirement to register a patient within like the Commission for the Blind, if they have that. But when they have it, they know, usually those are very good places to connect with resources. They know places with people with TBIs, places with people that do orientation and mobility, social workers, physical therapists, occupational therapists, and definitely it's important to go to a place that they have the source of this information that could guide you instead of finding little places everywhere. Because at the end you need that all the team communicate. For example, in my practice, I work at the hospital, and in Boston area there is a place that is called Perkins School for Blind, and they do a lot of this low vision or functional vision assessment. And we share the information. They communicate with me, I communicate with them, and we try to find things. And sometimes when we disagree about some of the aspects of the evaluation, we talk about it. Okay. And that's a thing that is in the better benefit of the patient. Okay. Then more than one person, I would say, trying to find places that can do this kind of integrate work.
Okay. One more.
Go ahead.
What kind of bulb, you were talking about lighting, you recommend the best for the kids with cortical visual impairment or with the kids, you know?
Nowadays, we don't have too many options about the bulb. All the LED are great. I feel that sometimes the cold light could be maybe too bright and could be a little bit uncomfortable. The too warm light, too yellow, also is like, it doesn't give a good contrast. Then nowadays, there's some lamps that give you the option to set this color setting in between. Okay. And those are great. And I would say more like this diffuse light. If you remember the old big lamp that illuminated the ceiling of the rooms, and you receive all this light, that was really good. Nowadays, we don't have that because there were halogen bulbs that they're not approved anymore. But now there's some LED devices that can provide that, like a diffuse illumination, because also a one focal, too bright light also produce too much reflection that could be difficult to deal with.
You are talking about like a lavender light, like the one they use in Europe, the one who are forbid here, incandescent light?
Yeah, nowadays we have mostly LED lights here, I would say. Then I would say, I don't remember the light temperature, but I would say not the stream of the cold light, not stream of the warm light.
Like something
in between. Yeah.
Thank you so much. I really appreciate it.
No, you're welcome. Thank you for your questions. Okay, is there anyone else? And also for that question, also one extra comment. At the end, you need to check with your child which one is the one. It's like a trial and error. You can see which one is the best and which one you react better. Because also could be some variability between patients who can prefer one type of light instead of the other one. Sometimes kids with the CVI struggle with the too bright places. Sometimes the kid needs a really bright light to have a high contrast. Then again, it's an individual adjustment.
Great, thank you for a great talk. I have two questions from online. I'll start with perhaps the easier, simpler one. I have a family whose child was diagnosed with Polar 3B with optic nerve atrophy, likely present at birth. They want to know, is that likely progressive, or you just sort of have it and it stays the way it is?
It's hard to tell again. Sometimes we have this optic atrophy. The nerve has so many fibers, more than 1.5 million fibers, that sometimes we see a very wide atrophic nerve that you still have a patient with a normal function. Sometimes we have a nerve that still looks good, but is not functioning well, because also we're seeing just the anterior part of the nerve. And what happened behind the nerve sometimes could take months or years to show up in the anterior segment. I would say the BP could help, but again, we have in the first year of life, the kids who have a normal development could have a more delay BP anyway, because the myelination of the fibers continue after birth, and then it's not something that is already completed.
Yes.
Then you still have I would say we have an age that it's really hard to be very strict on what you're saying. I prefer to be open about the diagnosis, because sometimes you can say to a patient that, okay, your kid couldn't see, and you can notice after a few months that the kid starts showing significant reaction or visual behavior that is not the perfect vision, but is enough to make the family to connect with them. Or sometimes you have kids that don't develop any kind of visual reaction.
Okay, thank you. And if we have time for one more question, this is from the UK. They have a child 6 with 4H. He's found to have bilateral optic nerve pallor a year ago via VEP testing. He's deaf, nonverbal, and struggles with esotropia, I hope I'm pronouncing that right, which began in one eye but now appears in both. Will these sight problems combined with deafness worsen his quality of life, and what vision loss should I expect?
I would say it's about the same as I mentioned before. The optic pallor is the clinical sign of the optic atrophy. But again, it's very variable, because sometimes the optic atrophy affects the central fibers, you can have a central deficit in the visual field, and you couldn't see well at all in numbers. Sometimes the optic atrophy can produce secondary that you couldn't integrate that information in a normal way. Then I don't like to give like a definite prognosis about vision, because we have learned that kids teach us over time, and I can extrapolate this also from kids that I see with retinal degeneration. We have some kids who are completely blind the first few months, and if you go and review the literature, you say, oh, for this condition, your kid is blind. And you see the kid seeing, showing visual behavior. And I always say, being too, giving a too definite idea about the prognosis of the vision could kick you back in two ways. If the kid couldn't see at all, it's super discouraging to tell you to someone your kid is not going to see ever.
Yes.
And on the other hand, to say that and then the kid shows some visual behavior, you look like a liar. You told me that my kid is not going to see. And let me tell you, instead of being super excited, the families, they look at you like, hey, you told me the opposite. Yeah. I was prepared for the worst. And instead of connecting and using that improvement as a part of the development and helping them to connect more with the therapy, sometimes use just the opposite effect. Then we need to know that it's impossible, and this goes also to the neurologist, even with the, I do electrophysiology all the time for vision, and we couldn't be certain about vision, because one thing is what we can measure, but sometimes the tests are completely flat and doesn't show any response. But our system has so much iteration, or has so many structures that are working this, trying to give us the vision perception, that sometimes patients with almost completely abnormal test, they can show us very significant signs of vision. And of course, for the prognosis, the only way to know that is to have at least 2 or 3 points to evaluate and see over time. I always say, if you go into a theater and look at the movie and take a picture of the movie, you maybe can do the right idea, get the right idea of the movie with that picture, but maybe you can get the worst idea of the movie. But if you go again later during the movie and take another picture, and then you take more pictures we have, yes, it's a better idea what we're going to have. And then this is for the families. It's not that we don't want to give you an answer about the prognosis of the vision, but basically we don't know. Because sometimes it could be better than we expect, but sometimes also could be worse, but we can navigate the situation together. And I would say all of us can learn, and especially in this kind of condition, they're so variable. And for the same condition could be so variable that, yes, try to do the best for your kids. Don't get discouraged. And of course, we are learning too.
Thank you. And thank you for your time. This was a great talk.
Thank you.